Hello everyone, let's study about the anesthetics. Now, anesthetics are of different types, but here in this video we'll be studying about local anesthetics. Local anesthetic has the suffix "cane". These are vasodilators. Now, here comes the two categories of local anesthetics. These are amides and esters. The amides are somewhat which is metabolized in the liver, and the esters are metabolized in the plasma. Here is the category. Amides are lidocaine, bupivacaine, atticaine, prilocaine, and those are metabolized in plasma, that is esters. These are procaine, cocaine, tetracaine, benzocaine. So the ester type of local anesthesia are much more toxic and more allergic, hence they are very rarely used. They are used only in the specific conditions where amides cannot be used. These conditions can be such as the person who is having any liver related disease. So at that time the amides can cause hepatotoxicity because um, they would not be metabolized and also will be reached in on a toxic level in the body and will be causing the negative effects. So at these conditions esters can be easily used. Now esters are used very rarely because one of the other thing is they consist of methyl paraben as an ingredient which is very allergic. So this is also a very important reason why esters are used rarely, but on conditions where it is required and where the mites are contraindicated, at those times esters are very helpful. Now amides I have summarized some of the points about amides. Let's go through it slowly and we'll be discussing other parts later. Now, lidocaine has a brand name known as xylocaine. Now it is packed as 2% solution. Okay, lidocaine is packed as 2% solution. So if the question arises that how much percentage of lidocaine is packed in a one capsule, you can say 2% solution. Now it is safest in children. So most of the time lidocaine is the drug which is used, local anesthetic which is used in dentistry because it is safest in children and it is an intermediate acting local anesthesia, so gives fairly good time to do the procedure, so hence it is used mostly. The second one is bupivacaine. It has the longest duration of anesthesia. The solution is 0.5% and it is not safe in children, so has to be considered with caution. Now the third one is mepivacaine. Mepivacaine is again used in 2% or 3% concentration and can be packed without the vasoconstrictor as well because they causes least vasodilation. So it should be noted that mepivacaine can be packed without the epinephrine as well because it causes least vasodilation. Now the another thing is articaine. Articaine is used in 4% solution. It is shortest acting drug, hence it has an ester chain as well. It is very important that articaine has an ester chain. So a part of articaine is also metabolized in plasma. Now if the question arises which local anesthetic can be metabolized in liver as well as in the plasma. The one is articaine, but it is the shortest acting and the solution required is 4%. So it is used in very selective conditions. Now the last one is prelocaine. Prelocaine is important because the question which is asked regarding prelocaine is that it causes methemoglobinemia, and this question is asked so many times. Now comes the pharmacodynamics. Before that, let's see a little bit about the esters as well. Esters, as I have already discussed, these are procaine, cocaine, tetracaine, benzocaine. The cocaine is a vasoconstrictor, so the one which is a vasoconstrictor and do not require a vasoconstrictor at all is cocaine. Here in amides, mepivacaine is the one which is one which can skip the addition of a vasoconstrictor because it is the least vasodilator. But cocaine is not a vasodilator, it is a vasoconstrictor, so it never requires epinephrine. Now comes benzocaine. Benzocaine is used as topical jelly of local anesthesia. Now comes the pharmacodynamics. Local anesthesia are sodium channel blockers. Okay, the inflamed tissue has acidic environment and have the non-ionized environment of tissue decreases, and the ionized local anesthesia molecules are not able to enter into the tissue, and hence the local anesthesia do not affect much. Now in inflamed tissue, what happens is due to the change of environment of the tissue becomes different than the normal pH. It can be acidic, and at this point the ionized form of the tissue inhibit the non-ionized environment of the tissue inhibit the ionized local anesthesia molecules, and they are not able to penetrate into that and do not able to bind up with the tissue, and this causes the inefficiency of the local anesthesia. To a some certain degree the local anesthesia will work, but that will not be clinically helpful for any procedure, so it is useless at that point. Hence, for these conditions, firstly the infection control is required. So in cases of severe, for example, a person is having acute abscess and that part is very painful, at that point first of all the antibiotics are given, and this prophylactic antibiotic is given and the infection is controlled, and later on the procedure is done. In some cases, if the patient is in too much pain, then it can be done that for example, if there is a root canal opening which has to be done and the pulp exposure is almost done, then the relief can be given by either access opening, but it will not be done under the LA, or because the LA will not be working, so it is mostly not preferred. But if there is an emergency procedure and they have to release the pressure, then it can be done. Or either sometimes the abscess can be taken out through a syringe as well to release the pressure, but in most cases the antibiotic regimen is preferred along with the analgesics. Now at least 3 consecutive nodes of Ranveer has to be blocked for a better anesthesia. This is important and sometimes it is asked in the board questions. So remember, 3 nodes are very important to conduct an impulse. So pharmacokinetics, what the body does to the drug. So increased blood flow means shorter duration of the action. For this reason, the vasoconstrictors are given so that the vessels around that particular area is constricted and the blood flow can be limited. Now, increased lipid solubility means more potent and long duration. This can be understood that lipid solubility with the tissue will increase the binding of the drug with that particular area, and this will cause the increased duration of the action. Now, increased protein binding, similar as above, causes long duration of action. Now, decrease in pK value is faster onset of the action. Okay. Now comes the calculation of the local anesthesia, and it is very important. So many times people get confused. Here are certain values which has to be remembered and some formulas which has to be applied to make the conclusion and calculate the value. So the things which has to be remembered is 1 ml in a carpool. 1 ml of liquid at sea level always weighs 1 gram. Okay, so 1 carpool is equals to 1.8 ml of liquid. This is a fixed volume of local anesthesia given to you in a clinic in a carpool. So 1 carpool is consisting of 1.8 ml of liquid. Now 1.8 ml of liquid means 1.8 gram of that liquid, which means 1800 milligram of that liquid. Now for 100% solution of local anesthesia, there will be 1800 milligram of lidocaine. That means if the solution consists 100% of local anesthesia, then there will be 1800 milligram of lidocaine. But if the solution consists 1% of this local anesthesia, then there will be 1800 divided by 100 into 1, which is 18 milligram of local anesthesia. So 2% of the local anesthesia, which we have already seen that lidocaine consists 2% of lidocaine in the carpool, and some other local anesthesias also consist mostly between 2 to 4 or sometimes 0.5. So by this method you can easily calculate the percent and the milligram of that local anesthesia. So 2% of lidocaine will be consisting 36 milligram of local anesthesia. Four percent of local anesthesia would be consisting 72 milligram of local anesthesia. Now comes vasoconstrictors. Vasoconstrictors are important as the prolonged numbness reduces the toxicity and promotes the hemostasis. Now toxicity. Let's talk something about toxicity. Maximum epinephrine for ASA1 patient, who is ASA1 is the patient who is systematically healthy, is 0.2 milligram. The maximum epinephrine dose for the cardiac patient is 0.04 milligram. Maximum lidocaine without vasoconstrictor can be 4.4 mg per kg, and maximum lidocaine with vasoconstrictor can be 7 mg per kg. Now, when a patient is taking warfarin medicine for the heart valve replacement, the drug of choice is articaine. For the pulpal anesthesia by the buccal infiltration. Why? Because firstly, buccal infiltration will not be giving a lot of local anesthesia to the system. It will be very localized and will have reduced chances of going systemic toxicity, because it is mostly infiltrated, not injected in the spaces, in the intramuscular spaces. So now the bleeding complications can be easily avoided. And second thing is, articaine is a short acting, so it will not be having too much time into the system. Hence, it is a good choice for the patient having warfarin medicine. Here, shortest acting. Now comes stages of general anesthesia. There is stage 1, which is known as amnesia or analgesia. In this, the pain is controlled. The second stage is delirium. In this stage, the unconsciousness begins, and this stage ends with the loss of eyelid reflexes. Purposeless movement and hyperreaction, dilated pupil, reflex vomiting, tachycardia, hypertension. These all things are suppressed. Now stage 3. Stage 3 is the surgical anesthesia. 4 planes with progressive loss of reflexes and muscle control. Now this is the part where a surgeon does his job, and the patient should be maintained in this phase until the surgery or the work is done. Now the fourth stage is the stage which is not desired. This is the medullary paralysis, cessation of respiration, ending with death without the proper treatment. So during the surgery, it is very important to look out for the signs that the patient should not shifted to the stage 4 but should be maintained on stage 3. And when the local anesthesia warns off, this slowly goes backward and comes to the consciousness. The above mentioned stages are for the inhalational local anesthesia rather than intravenous general anesthesia. This is for not the intravenous general anesthesia but the inhalational general anesthesia. Now, agents which can be used for the inhalational general anesthesia are halothane. Halothane is one of the most widely used anesthetic for general surgical anesthesia. The risk factor for halothane is, with epinephrine, it is risky for hepatitis, poor skeletal muscle relaxant. Then comes disulfiram. These have risk with epinephrine, sevoflurane, isoflurane, enflurane. Enflurane is a good skeletal muscle relaxant, and sevoflurane is having this advantage that it is not related to the hepatitis. Now comes nitrous oxide. Nitrous oxide is not considered as a general anesthesia since the hypoxic level are required to produce the anesthesia. Hence, the nitrous oxide are not the anesthetic but a sedative. It is a gas at room temperature used along with the general anesthesia to supplement the anesthetic response. So it is helpful. It synergizes the response of the anesthetic. Now it takes 50% less time for normal sensation to return when an antagonist of an anesthetic such as phentolamine mesylate are given. Example, if lidocaine takes 180 minutes to warn off, then after injecting phentolamine it will be 90 minutes. Oraverse is administered as the submucosal injection. Local anesthesia injection must be 1 carpule per minute as fast deposition will cause pain and discomfort to the patient. Now the gauge needles which are used. The red color is indicated for 25 gauge needle, yellow for 27 and blue for 30 gauge. And mostly which is used is red needle which is having 25 gauge because this is having better aspiration and less deflection. The 30 gauge one is very thin needle and the yellow one is medium. Now there are several type of blocks which can be given by local anesthesia. The first one is inferior alveolar nerve block. This has highest failure rate. Now it numbs all the mandibular teeth in that particular quadrant, like first quadrant, second quadrant, third or fourth. Lingual nerve is also anesthetized and it will also numb half of the tongue of that particular side. So first and fourth quadrant will numb the patient's right side of the tongue. First, not obviously the fourth quadrant, and the third quadrant will be numbing the left side of the patient's tongue. Inferior alveolar nerve block is a mandibular nerve block. First of all, this is very important, and it will numb the teeth of fourth quadrant or the third quadrant. The nerves which are anesthetized in this is inferior alveolar nerve, lingual nerve, and if the procedure has to be done related to the mandibular teeth, so that particular quadrant needs the blocks which are inferior alveolar nerve block, lingual nerve block and the buccal nerve block. So buccal nerve block is given to the third molar, related to the third molar, buccally to the third molar, and causes numbness of the buccal tissue by blocking the long buccal nerve. Then there is a mental nerve block. The mental foramen is the exit point of the mental nerve, and this point is near the apex of the root of the first premolar, lower first premolar. This is also having incisive nerve block which is not very much used, but these mental and incisive nerve blocks only anesthetize the lower anterior teeth. Then comes posterior superior alveolar nerve block. This is given in the upper quadrants, first and second, and it is useful for the blockage of the nerve sensation of the posterior teeth, mostly molars, first, second, third of first quadrant and second quadrant. These are for maxillary molars. The block is given 45-degree angle bisecting second molar medially upward buccal to the third molar. 16 mm depth of the needle should be there, and if you want to roughly see, then half of the length of the needle should be inside the tissue, but not too much far away, because it can cause the rupture of the vessels at this particular area, and which can cause hematoma formation, which is a very common errors of this particular block or complications of this block. Also, the trismus is very common complication of this block, because it is also asked so many times, trismus can be caused by which of these following blocks or which of the following area. So the infratemporal region is the answer, and posterior superior alveolar nerve block is the answer. Now comes infraorbital nerve. Infraorbital nerve blocks the anterior superior alveolar nerve and middle superior alveolar nerve. This will cover the anterior teeth plus premolars and the mesial root of the first molar of the maxillary jaw. So the next one is greater palatine block. This is given to the palatal side of the maxillary jaw. Injection on posterior hard palate 3 mm towards the midline palatally to the second molar. Numbs the palatal part of the upper molar and premolar. Now comes nasopalatine block. The nasopalatine block is a block which is given when the numbness of the palatal side is required from canine to canine. It is considered as the most painful block and given in nasopalatine foramen palatal to the anterior teeth. Next one is the local infiltration. Now local infiltration enters in the vestibule and aim for the root apex. This works best for the maxillary teeth because the bone is not that dense as of the mandibular teeth. Now the next topic will be antibiotics. So this was all about the local anesthesia. I have covered all the important points of the local anesthesia, and if you want to know more about the some other question related points, then you can also watch other videos which is having the title of important points in the pharmacology. I have covered some of the questions which I have seen in the INBD test series and everything, which every material which was provided on internet on different sites. So I have compiled some of the questions regarding it, but those materials were not confidential. They are available for everyone for free, and some books also provide the material regarding these questions. And also I have made certain notes related to my experiences of learning during this process. So all of them is compiled in those videos, so you can watch, and there is a lot of questions which are related to the INBD and frequently asked questions. So bye bye and see you in next video.